our next presentation, which is by Dr. Ragini Kudchadkar, who is an associate professor of hematology and oncology at Winship. She's also one of the co-directors of our melanoma program. She's going to talk about the very interesting topic of triplet therapy for melanoma. Dr. Kudchadkar.
Thank you so much, everyone, for having me. And this is a topic that is, honestly, we are all debating. So I'll do my best to share it with everyone. And let me just share my screen here and we can get started. All right. Let's get started here. So the first real question is, what is triplet therapy? Triplet therapy is really therapy for melanoma patients whose melanoma has the BRAF mutation. And it's using those targets towards the BRAF mutation combined with a drug that blocks the PD1 pathway. And I know many of you on the call are familiar with a lot of these drugs, but just in case there's anyone that's not, there's a lot of drugs that are used in this era, and every drug has a million different names. And so I thought right here, I'd just go over some of the drugs I'm going to talk about in the studies that have happened. So pembrolizumab, brand name is Keytruda, we may call it Pembro for short, is a PD1 antibody, an immune therapy. Spartalizumab, which actually I don't believe has a brand name yet, is a Novartis PD1 antibody. And some of the studies you may, if you Google it, it used to be called PDR001. Atezolizumab is Tecentriq is its brand name. You may hear me call it Atezo because these names just get far too long. So all three of those are immunotherapy and monoclonal antibodies against that PD1, the whole pathway. Dabrafenib and trametinib target that BRAF genetic change in melanomas, and vemurafenib and cobimetinib are drugs that do that too. You can see the brand names here. There is a third company that makes what's called encorafenib and benimetinib, which also target the BRAF/MEK pathway, though I'm not going to kind of discuss those in our talk today. So just to give, you know, all these alphabet soup is what I would call this, but basically you have a cell, there's things outside the cell, and it goes through different mechanisms to tell your cells to grow. And in your cancer cell, what happens is, I'm sorry, I'm just gonna put all this on there, is this BRAF, this part of the pathway is kind of stuck in the on position. And so you can see here that the drug dabrafenib and vemurafenib block it here to try to tell the cells not to grow. Trametinib and cobimetinib are used in combination because we found if we block just one place, the cell kind of figures out a way to go in another place and block the MEK. So we find that doing it together is better. Just to give you guys an idea of how these drugs work. And the PD1 pathway is working between the tumor and the immune cells. So you have your T cell that's trying to fight the cancer that gets exhausted. The gas is just not in there anymore. And the tumor cells can actually do that by blocking the PD1 through PDL1. And I know this is just a lot of terminology, but when we're going over these drugs, what we're trying to do is activate those T cells. So you can see here the drugs that block the PD1 side of things, and atezolizumab actually blocks the tumor side of things in the PDL1, both resulting or all resulting in T cell activation. So this is just a little bit of background about the drugs themselves and a little bit of terminology. So there's actually 3 major clinical trials, and the goal of quote unquote triplet therapy Everyone is super excited about immune therapy. We feel like the immune system has memory and can give patients long-term durable responses. But we also know that these drugs that block that BRAF, the targeted pathway, can give high shrinkage rates. There's also some science that maybe those drugs that we're calling targeted actually are enhancing the immune system as well. So the question is, you'll learn as oncologists, if we can do good with one, we want to do good with everything. And so we tend to go the kitchen sink approach. So can we combine the two and get the cancer to shrink at a high rate, but also get that durability, that long-term response that we need? So there's 3 big trials. They have cute nicknames: Keynote 022, Inspire 150, and Combie Eye. So these are the 3 big studies that have come out very recently. I think some of these were published just in the past few months. And as a melanoma community, I think we're trying to figure out what all this means and how do we best use this combination for our patients. And so I'm going to briefly go over what these studies are. So Keynote 022 is a phase 2 study. It's probably one of the smaller studies that are reported now. Phase 3, which is the larger study, is ongoing. So this is a study that had 60 patients in each group. So the quote unquote standard group was the group that got dabrafenib and trametinib that blocked the BRAF mutation. These are all patients with stage 4 melanoma, so melanoma that's outside the local area in the lungs, liver, somewhere else. And all patients had, or at least their melanoma had, that BRAF mutation. So that mainly because these drugs like dabrafenib and trametinib, if the cancer doesn't have that, it doesn't work. So you don't want to use it. So it's just for those population of patients. And comparing that standard to combining it with pembrolizumab with the immune therapy. So what these studies were looking at is what we call progression-free survival, but what that really means is how long can you stay on these drugs without the cancer figuring out a way around it? It doesn't mean that these patients don't go on to different therapies and can't still do very well, but how long? A lot of our studies use terminology like median. I find that doesn't, at least for me, all that helpful. I mean, for me, I want to know, how well are you doing 1 year, 2 years, 3 years on these therapies? As you can see here, the data is about 1 year. And about almost 60% of people's cancers were still shrinking at 1 year on the triplet. And it was a little over 45% for the doublet. Now, that being said, it actually didn't meet its primary endpoint. Though there was a trend to being better, beyond my knowledge statistics, what they had defined as truly being better wasn't met, but there clearly was a trend. Now, it did have side effects. The triplet did have more side effects, fever, rash, diarrhea being the most common. The doublet had fever, nausea, and fatigue. There's severe side effects. So if you guys are ever trying to read studies, a lot of them are reported as grade 3 or above, which to me means something that lands you in the hospital, makes you sick, changes, your everyday life, versus something that, is bothersome, but not necessarily makes you go to the hospital or be admitted. So what triplet therapy had, 58% of patients had severe side effects, mostly things like fever, a lot of changes in your liver tests, which are called the AST, ALT, and immune toxicity to the lungs was noted, which is a known side effect of the PD1 antibody. With the doublet, those severe side effects were a little over a quarter of patients. Now, moving on to Inspire 150, which was looking at Combie, which are a different BRAF MEK inhibitors, along with atezo, again comparing it to the standard, which were the BRAF drugs alone. This is a much larger study, almost 500 patients with stage 4 melanoma. Done a little differently. You got a month of getting the BRAF drugs, and then the atezolizumab was added. But similar results of that. How many people were still on drug whose cancer was still shrinking at 1 year? Similar results to the other study, about 54% versus the doublet, about 45. You can see as time went on, they did report 18 months of data, but the triplet was still doing a little bit better. So this actually led to the FDA approval of this combination. Still, the side effects were very similar to what I talked about earlier. CPK is a muscle enzyme that's in the blood. They noticed that. Rash, diarrhea, fevers, a lot of liver test changes. So very similar to what was seen on other trials of these agents that we've discussed. But I think it was a larger study, though it had similar data to the smaller study. But statistically, this study said doing the combination was better. Now we're going to talk a little more about what does better mean and whether better is truly better in just a minute, but wanted to briefly mention the last study, which is the Combie Eye, which is dabrafenib and trametinib with their, I think it's Novartis's PD1 spartalizumab versus dabrafenib and trametinib alone. And I put here the press release that Novartis let out just, I think last month or very recently, which I say is a very, very nice way of saying that the study was negative, meaning the dabrafenib trametinib on its own was just as good as the combination. Of course, they said it probably a little more eloquently, or basically said that the combination did better than they expected, which is why it was negative. But in general, it showed that doing everything together may not be quite as good as we thought it was based on some other studies and based on the earlier studies of this agent. One, I think this really proves the importance of not making conclusions too quickly. You know, I think especially when we're dealing with such a serious illness, there's a tendency to say, oh my God, the study's showing in 10 people that it's doing so much better. And it's an importance of doing clinical trials in this way. And I just so appreciate all the patients that went on the studies to answer these questions and make sure we are doing the right thing for our patients. So I was hoping that David or whoever's on the panel would help me discuss what all this means, because we have two studies, one very small, only a phase 2, that had a trend to benefit but not statistically benefit. We have one study that came out saying no, the two ways of doing things were that one was not definitively better. And then we have one study that led to FDA approval. All the studies clearly showed toxicity. And in my mind, toxicity is very important, but if it's clearly going to make people do better and do better in the long term, you know, I think we will all accept some degree of toxicity. Now, this being said, where do we go from here? When is this appropriate? You know, it's like you have three choices: never, always, because it's approved in the frontline setting, or maybe there's a select group of patients that need this therapy. And how do we figure out who these therapies are? In my gestalt of all this, I think in general, we don't really have the data that really tells me that doing triplet, doing them all together is better until I know how people are doing in the long term. the whole goal of the triplet was really to increase the rate of people that are doing well in the long term, and we just don't have the long-term data yet. You see these things at 1 year, 18 months. I don't know what happens at 5 years and 10 years for these people to really prove that it's better. And in my mind, I don't think looking at everything, it's really proven that it's better for most patients. I think there's probably a very select group of patients that need all this up front and need to be exposed to the toxicity, but who those patients are right now, I think we're still trying to tease out and still trying to work out. And David, I don't know, I would love your opinion on how you think this should be used and how you interpret conflicting data among studies, granted with different drugs, but similar pathways being targeted.
Yeah, I first thank you very much for that review. It is a confusing area, to say the least. I think, though, that the other thing to consider, of course, is COVID itself. That and how do you think that the fact that we are in the midst of a pandemic would affect people's thinking about trying to take on, therapy that's so openly toxic. And I tend to think for myself that it's still a viable research question. And I think that it is a therapy that you might consider for some people. But I tend to think, like you, I believe, are thinking that we really need to be careful about how we go forward with these things. I can say that the cooperative groups and other groups are still interested in trying to investigate these triple therapies, and so I would encourage people to participate in those trials.
I agree. I think there's a lot to learn as far as where to go. I know we have an FDA approval. I don't think in general it's going to change the standard of care for patients, but I think, choices are always good for patients, and I'm excited to have more choices to offer them and more, but it does get more complex decision making in how to know what to do. And I think making sure as a patient that you're getting care where someone can really go over these pros and cons and look at the risks from other things in your environment and yourself to kind of make that decision. Choices are always good, but I don't think I've yet gotten on the bandwagon of triplet therapy. Yeah. I just want to lastly say, remember to vote if there's no other questions. The lines have been long here in Georgia, but I really appreciate everyone doing their part.